your hands by using the click the icon on the screen, and then the moderator will going to receive a request for you to unmute yourself. Once it is accepted, you will be able to talk and share your opinions with us. So hello everyone, welcome to the Minamata online event. So COP5 events are an informal platform for the parties and observers to share information and bring knowledge to advance in technology, research, and policy to the attention of parties and to the global community that the convention serves. So we are excited to share a lot of interesting events with you. This is the last one of today, and we still have 4 more going on tomorrow. And please kindly know that this session is being recorded and broadcasted live on YouTube. And to help us improving the experience, please fill out the survey at the end of the webinar. That would be highly appreciated. And without further ado, I will give the floor to our moderator.
Thank you. I'm Ruth Littman from the ADA, and I'm very pleased to be moderating this session, and thank you for joining us. Today's speakers will provide data on the multifaceted progress towards phasing down the use of amalgam and will serve as grounding for the discussion about the proposed amendment from Botswana and Burkina Faso. We will start with a presentation by Dr. Jagadat, Communications and Advocacy Director at FDI, about the progress on the phase down front while incorporating intention on population oral health.
Thank you very much. So if we go to my first slide, for those of you who may not know who FDI is, we are a member-based organization. So we have 189 national dental associations or specialist groups that are part of our membership in 133 countries, and we represent 1 million plus dentists globally. So if we go to the next slide, what we're here today to talk about is what has been the progress in the phase down of dental amalgam. And what we've seen is really great momentum over the last few years, specifically with political processes that have been implemented to support this. So, as you know, the Minamata Convention entered into force in 2017. And since then, we were really pleased to see that an oral health resolution was adopted by WHO member states in May 2021. And this was key, and I'll go into more detail on this later, but as resulting mechanisms from this was the Global Strategy on Oral Health in May 2022 and an action plan in May 2023. And in the middle of all of that, in September 2021, there was dental preparations were included on the oral in the WHO essential medicines list too. Why was this important? Well, for us, it was key, aside from cost-effective alternatives to dental amalgam being introduced. What was key for us was there is fluoride included in there, fluoride toothpaste, varnish, gel, etc. This is key because for us, prevention is where we want to focus. Prevention, we don't want to get to the point where you're having to treat people. We want to prevent in the first place. So again, that was a really great achievement in terms of political progress. And then, of course, some of you may have joined the webinar earlier this week that was driven by Jeff, WHO, and UNEP, and really talking about this GEF7 project. And my colleague Makiba later will also highlight and go into more detail on this. So what I really want to focus on my next slide is what has been what does this mean? What does the oral health resolution, if you click through, please? The first point to say is that there's been a call for within the resolution, strategy and action plan driven by WHO member states and adopted, there is a call for the phase down on the use of dental amalgam. And what's important to highlight here, it mentions that it needs to take into account domestic circumstances. That's something that FDI, IADR and our members have been pushing for, because there is no one size fits all solution. That's what we've been saying from the start of when the convention came into force. You have to take in, the strategies have to be developed according to national circumstances. Secondly, what do these processes say? It says that there's recognition that a viable replacement material needs to be developed through focused research, which is also safe, effective, accessible, affordable, and of course also has to be environmentally sound. You don't want to replace dental amalgam with something that may be worse for the environment, or maybe bad for the environment, should I say. So in terms of the next point, what we say is that what these processes also mandate is for WHO to develop technical guidance by 2025 on environmentally friendly and less invasive dentistry. Again, this is key to our global membership, but also those in the oral health community, in order to learn from this technical guidance. What is WHO going to help produce and support us with? And finally, on this slide, I think another thing that FDI, IADR, and our members have been pushing for is the collaboration between the Ministry of Health and the Ministry of Environment. And again, these political processes are now calling for that and are highlighting that this is absolutely critical on a national level. If we move to my next slide, here what we'll see is within the Global Oral Health Action Plan that's been adopted by 194 WHO member states, there is specifically a target included within that on the environmental sound oral health care. What does that say? It says by 2030, 90% of countries have implemented measures to phase down the use of dental amalgam, as stipulated in the Minamata Convention. And again, this is great. We're seeing where the Minamata Convention maybe at the beginning was very much seen as siloed and very much an environment treaty with maybe the health considerations not taken into account. We're seeing how all these sort of gaps are being filled through these mechanisms. So if we move to my next slide, again, just to highlight what does it mean? What impact will the Global Oral Health Action Plan have, and what impact is it having actually? What is this mechanism going to do? Well, it very strongly embeds the Minamata Convention dental amalgam provisions in the targets and indicators. And just to mention, this is by the key tool by which countries will be monitored and measured progress on. It also calls on WHO to work in collaboration, and we saw that working very nicely through their webinar earlier this week with the Secretariat of the Minamata Convention, UNEP, and GEF, in order to ensure the acceleration of the implementation of the phase down provisions. And I think key to that is really providing and strengthening country capacity in the environmentally sound management of associated waste as well. So if we go to the next one, you'll see here that what does this all mean? Well, it's key. Over the years, we've been breaking down the silos. We're speaking the same language, and this has resulted in progress. And this is something that is you've seen across the political processes that I highlighted earlier. If we move to the next one. So again, as I mentioned, my colleague Makiba will talk about GEF 7 in more detail. So all I want to highlight here is that our members want to learn from the evidence-based demonstration projects that are happening as part of this GEF 7 project. What were the challenges? How did they overcome the challenges? How did they improve waste management? And how were the prevention strategies successful? So this really is a key project. And again, we'll hear about this more later. So what did FDI members in fact tell us about phase down, of what they're doing to accelerate the phase down of dental amalgam? If I move to the graphs on the next slide, well, FDI, as part of its Vision 2030 advocacy strategy, carried out a comprehensive survey in 2021, and within that we included questions around awareness around the Minamata Convention and actions that they're taking on a country level. And the question of whether they are aware of the implications of dental amalgam and the convention, we were pleased to see that of the 77 respondents, 88% said they were. And then when did their country have a phase down strategy? Of the 64 respondents, over 70% said they did. And I just want to highlight here, unfortunately, I don't have the results of maybe a few years back, and these graphs certainly would have looked really different, these pie charts, because from conversation, FDI, one of the key roles that FDI and IADR play is also educating and growing awareness to its members of what's happening on the global political landscape, what treaties are being signed to, and how that's going to impact them on a national level, and really working with them to ensure the provisions are being implemented and tracking progress. So if we go to the next, you'll see that when we actually then drill down and said, okay, so which of the 9 provisions are you implementing? You can see in terms of sort of the ones that were highlighted, I guess, as the most popular ones, were the promoting the use of environmentally sound practices in dental facilities. That was number 1. But then also they are setting national objectives on minimizing use. And then in the third highest, should we say, ranking was in terms of making sure that the right education and training is happening in terms of using mercury-free alternatives within practice. But it was good to see that there was progress, at least in the provisions being made in the other provisions too. So again, this is highlighting that progress is happening globally. So on the next slide, so how can implementation be further accelerated? So if we go back to the next, so if we move on, sorry, and we go back to the slide I presented at the beginning, you can see that it's great. We have the ministries of environment now working with the ministries of health, global level. You've got the GEF7 project. This needs to trickle down nationally. And what our members have been telling us, the national dental associations who are doing the work on the ground, is, and what we've seen is where they're involved in these development of strategies and plans for phase down, then more effective results are taking place. So what we're saying and what we know is the multi-stakeholder partnerships on the ground need to be happening. So our national dental associations need to be involved, researchers, private sector, but also dental schools, academia. Essentially, they need to be trained and on the alternatives, and also they need to be educated on the mercury-free alternatives. And then, of course, none of this can happen without the effective budgets being allocated. So if we move through to my final slide, summary slides, what we would say is, and we'll click through one by one, 6 key learnings. Well, the first one being, as you've seen, the phase down approach is working. Secondly, what we want to see is we have to and we must learn from the GEF7 projects. We're looking forward, our members are looking forward to the results coming out from those demonstration projects, and seeing how we can implement such learnings on a national level. Thirdly, of course, what is key is alternative materials. Any alternative materials that are coming out must be safe, accessible, and also, I should say, of good quality and affordable. And related to that, on the next learning, is that we need more research on the alternative materials, including their environmental impact. We don't want to replace mercury with something else that may be even may be harmful to the environment too. And then where we are moving is, with all of this, waste management still remains the most important action point, even in a phase out scenario. But I think I'd like to end on the final point, which is, for us, emphasis on prevention remains crucial and should be prioritized. We don't want to be carrying out treatments. You know, caries is the cause of the most prevalent disease. 2 billion people are affected, with over 500 million children. We don't want those. We want those numbers to come down. And the way to effectively do that is prevention, so that we don't need treatments in the first place. And thank you. That was my last slide.
Am I on next?
Thank you. Thank you
All
for
right.
that introduction to the speakers. We're going to now hear from Professor Umase, who is a senior lecturer in the Restorative Dentistry Department of Medicine in the University of Lagos and Lagos University Teaching Hospital in Nigeria. And she's going to discuss the national experience, illustrating why the phase down should be prioritized over an immediate phase out. Donna?
Yes, please. Okay.
Excellent.
Thank you so much. I'm right here with you. I'm going to talk on why the amalgam phase down and not the phase out approach should be prioritized. All right, next slide, please. All right. So amalgam has been in use for more than 2 centuries and has a long history of being a safe, durable, and affordable restorative dental material. Until recent years, when resin composite and other adhesive restorative materials became more available and predictable in their performance, amalgam comprised 70% of restorations placed to restore curious teeth. The decline in the use of amalgam, we know, has been motivated first by patients wanting aesthetic restorations, and more recently by the phase down of mercury, consequent on the Minamata Convention on mercury, the phase down of amalgam, consequent on Minamata Convention on mercury. Next slide, please. Now, the Minamata Convention on mercury generally is a worldwide commitment to reduction and ultimate cessation of production and use of mercury-containing products. That is a ban, outright, or a phase out. Nigeria signed the convention, as we know, October 2023, ratified it in 2018, and we know that there are about 128 countries as signatories and 147 as parties. And the convention came into force on the 16th August 2017. Please, next slide. Okay, just to say that I was at the FDI convention in 2017 when the convention came into force and amalgam phase down was announced. Next slide, please. Dental amalgam, right, is the only mercury added product that has been subject to a phase down by the Minamata Convention. Over the years, dental amalgam has been the primary material for restorations in people worldwide. So it's not surprising that we're talking about this material, as more than 90 people worldwide been said to be affected by dental caries. Next slide, please. So let's look at the continued use of amalgam. Despite the controversies surrounding amalgam and the planned suspension or stoppage of amalgam use, it is still in clinical use in a number of countries, including Nigeria. This is because of its high strength, ability to withstand high masticatory forces, its ease of use, low technique sensitivity, and its erstwhile low cost. As the phase-in of amalgam is progressing, amalgam has become less available and more costly to obtain in countries like Nigeria, where it is not produced. Next slide, please. Use of adhesive materials. Adhesive materials are more technique sensitive and they require fully functional dental units and uninterrupted electricity for good success. In many developing countries, which are resource challenged and suffer lack of technical support for the maintenance of these dental units, even when they are when they're purchased brand new, it would seem that that may be a challenge. Unstable electricity power supply tends to compound the problem. as the chairs easily get run down due to power fluctuations and outages. And this also makes functional accessories such as suction machines unavailable, thus impacting negatively on the placement of adhesive restorations. Next slide, please. So what are the challenges in the event that we decide to phase out amalgam? The endocaries seem to be on the decline worldwide due to the universal usage of fluorides, fluoride-added products, and other caries preventive protocols. However, in developing countries, there's still the issue of late presentation of patients having very large carious lesions, and such large lesions may be out of the scope of minimal intervention dentistry, and they require restorations that can withstand the heavy masticatory loads in the face of hard and fibrous diets. So the question is, are the mercury-free alternative restorative materials as tough and resilient as amalgam? That's a question that we really need to ponder on. Next slide, please. So what are the recommendations? Amalgam phase down should be observed for a longer time to come in developing countries to allow for education of more dentists and dental students on the use of mercury-free alternatives. National oral health policies should be put in place, which encourage mandatory periodic dental checkups among students, staff in primary schools, pre-primary, secondary, and tertiary institutions, workplaces, and every organization, all in the attempt to catch caries early, and of course, prevention. Caries prevention, oral health, education, and promotion should be intensified in developing countries and indeed all nations. Next slide, please. More research is needed to determine the efficacy and effectiveness of mercury-free restorative materials. Dental school curricula should be modified to pay more attention to the techniques required for successful placement of adhesive restorations, as the protocol for their placement differs from the protocol for amalgam. People tend to handle adhesive materials as if they are handling amalgam, so they need a lot of retraining for good success. Local research should be encouraged in developing countries to develop new restorative materials that are mercury-free and robust enough to serve within the context of the limited resources and infrastructure. Next slide. In conclusion, I will say that amalgam phase out may be inevitable, but the developing countries and indeed all countries need to be assured that the mercury-free alternatives are user-friendly and as good as or better than amalgam. Thank you very much for listening. Next slide. And those will be my references. Thank you so much for the time. Greetings to everyone.
Thank you, Professor. That was very interesting. We'll next hear from Dr. Schmaltz, who is a professor of operative dentistry at the University Hospital in Regensburg, Germany, who will share some technical data and insights about the merits and challenges associated with the use of glass ionomers, composite cements, and new materials that are on the horizon. Dr. Schmaltz?
Okay, thank you very much, Ruth. Also welcome from my side to all attendants. I will talk about amalgam alternatives, which have been mentioned in the recent talks, and especially about the research advancements. Next slide, please. So we are normally treating our cavities using filling materials. We make direct restoration, so we place the filling material directly into the cavity. Next. And here you see example for resin composite materials, the cavity and the filling material. We can also use other materials. Next. So like glasionomer cements, and I have some pictures. Next. And you can see here in these teeth that glasionomer cement, different materials have been used for restoring teeth. Next. Of course, we can also use indirect restorative materials for crowns. Next. And for inlays and partial crowns, but they are much more expensive. They need laboratory work, and therefore we will not cover this in my talk. Next. yeah, we come to resin composite next. And so the main point is how long does they stay in the mouth, the longevity, of course. Next. And here you see a nice composite, resin composite filling after 3 years. This looks very good. Next. But we have also failures. You see here secondary caries and fractures. So the question is, how is the state of the art for resin composites and longevity? Next. There is a literature, so-called meta-analysis. So studies have been compiled, different studies, and you see here on the left side favor of amalgam, on the right side favor of resin composites, and you see there are some studies which have the results which are more or less the same for amalgam and composite, but there are a lot of studies favoring amalgam, and if you add this all up, you see that still the longevity there is a favor for amalgam, and especially, next please, especially in patients with large defects and lacking good oral hygiene, we have a problem with resin composites, and in those cases, amalgam is, as the data show us, show the better, longer longevity. Next. Beside this, this has been already mentioned, resin composites have a complex technique, and here you see some of the steps. There are in reality even more. On the left side, you see the cavity, then the prepared cavity, then there is some etching applied to the cavity, then some adhesive in between. It must be rinsed. The adhesive must be light cured, and then we put different layers of the composite material into this cavity. Each layer has to be light cured again and again. And then after this, we have to finish the restoration, polish it, and then on the right side, it is finished. So this complex technique is the reason for what I will talk about later, the higher cost. It is not the material, it is the complex technique. Next, please. And here you see information on the costs. You can see that experiences in Norway, where we have phased out amalgam, show that there is an increase in cost between 30 to 50%. And this has been shown also in other studies, so it will be more expensive. So this is also true for the so-called bulk technique, which requires less layers. Instead of 3 or 4, maybe only 2 or 3. But still, the technique is very complex, and data have shown that, again, it is rather cost intensive. And the reason, again, is the technique. And the consequence has been lined out in the literature. If resources are missing, more extractions and more oral health inequalities may be resulting worldwide. Next. So are there cost-effective alternatives? And there are, of course, the class ionomer cements. And one of the first was a high viscosity glass ionomer cements. Next. And here you see one of those fillings of this high viscosity glass ionomer cements. Next. So the technique, we have some dry operation field. You must put some condition on the cavity, material application, finish, and that's it. Okay, so it's easier than composite resins. And the WHO has recommended that for the ART technique. What is that? Next, please. The ART is the atraumatic restorative treatment. This is a special technique which has been developed for developing countries in areas where you have little or no access to sophisticated machineries to make normal dentistry and dental treatment. This has been shown to be mainly good for class 1 cavities. As you can see here on the occlusal surface, this is a class 1 cavity. But generally for bigger cavities, this has not been found to be to show good longevity. Next. And the reason are the technical properties of this material. The mechanical strength. You see on the bottom 3 bars, right, the composite resin, then resin modified glass ionomer cement and modified glass ionomers. And if we go to high viscosity, they are 20% less than the modified glass ionomer cements. So next, please. So what is the consequence? The consequence is what we call class 2. Next, please. So here we see class 2 cavity, and on the chewing area, on the occlusal face, surface, if you bite on it, next please, it breaks. And this has been shown in literature that these materials are prone to fracture. Next please. Yeah, next. So now we have the modified glass ionomer cements. They need some coating. I will explain this to you. Next, this is one of the fillings. This looks like how the filling looks like. Next, please. So the technique, again, preparation field, cavity conditioner, material application, finish, and then you need a coating, which is a methyl methacrylate, and some light curing. Next, please. Again, the technical properties are not as good. Next, please. And we have a resin coating. Methyl methacrylate is used for that, which is quite an allergenic material. We need, again, light curing. The costs are increased, and the clinical evidence is very limited. Next. So again, as I showed you before, these are the modified glass ionomer cements, the left column down, the left one. Again, there is a high probability that it may fracture. Next, please. So there are another group, which is called resin-modified glass ionomer cements. Next, please. And here you see one of the fillings of glass ionomer cements with resin. Again, you need a dry operation field, cavity conditioner, and adhesive. You need material application and finish. Next. The problem, again, the mechanical properties are not as good as composite resins, but they are better than the others. Next, please. As you can see here, is the middle column. And therefore, these materials can be used for deciduous or primary teeth because these teeth had a limited lifespan anyhow. Next, please. Yeah, now we talk about the safety. Amalgam has been discussed a lot, and I just brought with me some newer data from 2020 and 2021. Literature compilation from the International Association for Dental Research. And they have shown that best available evidence that IADR affirms the safety of dental amalgam for the general population, which is important, without allergies, for instance, to amalgam components or severe renal diseases. And this has been supported by the FDI statement in 2021. So for the alternatives, especially for the resin composites, there is a report from the European Scientific Committee, CENIR, on emerging newly identified health risks, and again on the IADR 2020. And it says that non-mercury containing alternatives are not free from any concerns about adverse effects. And these can be cytotoxicity or genotoxicity. There's bisphenol A release from many of those materials, and we have absolutely no idea what these materials do to the environment, what the microplastic will do. So we have no information on that. Next, please. Yeah, so we are just looking for newer and better materials. Just give you a few examples of better materials or newer materials. And these are all studies from the laboratory. You see a picture on the left, which says leakage. Leakage is where saliva can enter between the filling and the cavity. And this can be the beginning of the secondary caries, which we do not want. So we can change the resin compartment of the filling. The resin degrades, we know this, and the resin shrinks. So we have new molecules now under development. And you see on the graph on the right side, the bars of the leakage. The less the bars, the better the material. And you see some of the materials, ring opening materials, are very little shrinkage. Next slide, please. There are other research going on, for instance, on new adhesives, on one-step universal adhesives, on self-adhesive materials, on so-called multifunctional bioactive materials. Those are materials which, for instance, are antibacterial, or alkalides. These are resin composites which contain alkaline fillers and primer, and they can counteract the acidity of caries. But if you look at the years when they are investigated, you see 2022, 2022, 2021, 2022, and also the glass ionomers, the modified so-called glass hybrids in 2021. And all these data are mainly derived from laboratory or from very short clinical studies. Next, please. And this is the challenges of our work. Of course, we need laboratory data, bench data, because we need them to select the best candidates. But the predictivity for the clinic is limited. So what we do need is randomized clinical studies, bedside studies. And the problem is, and this is different to medications, testing, medicaments, the success of restorations cannot be evaluated in a couple of months, but only after 5 to 10 years. So this makes life a little bit difficult. And the costs, we know this presently, new general amalgam alternatives are available only at higher costs. And finally, this has been mentioned also, implementation into healthcare system takes time. Next, please. So this is my last slide. We come to the conclusion. Yes, new alternative materials have already been developed. They are partially clinical tested, especially the resin-based composites, but still problems exist for the affordability, durability, and safety. And as has been mentioned at the beginning, a one-fits-all is not working. There are strong research activities underway, and if you go to a scientific meeting these days, there are lots of these papers discussing and new products and presenting results on new products. However, I showed you the inherent technical problems, and frankly, no reliable indication of a timeline can be given for a worldwide scenario of a phase down to a phase out. But two things can be sure: the better, the longer, the better. And support in research certainly will accelerate the phase down of dental amalgam. I think this was my last slide, and I thank you very much for your kind attention.
Thank you, Gottfried. That was interesting and informative. And now our last presentation today will be by IADR's Director of Science Policy, Dr. Makiba Charles Ayindi, who will provide us with an update about the GEF7 project that is currently underway in Senegal, Uruguay, and Thailand. The first phase of which is designed to identify the most significant stakeholders who can be engaged in order to successfully phase down use of amalgam. And then in the second implementation phase, turn this into reality. Makiba?
Thank you, Dr. Lippmann. So we recognize that it is critical to phase down the use of dental amalgam systematically and strategically due to the global prevalence of oral diseases. Estimates show that almost half of the world's population suffer from oral diseases. The disability adjusted life year, which is a measure of the number of healthy years of life that is lost, it is just staggering, with no notable improvement since 1990. So it is important to note that as folks live longer and the population continues to age, this burden is just expected to continue to increase. When we look at the prevalence of diseases across sexes and just where oral diseases ranks in that listing, it's number 1 and has continued to be number 1 from 1990 up to 2019. Again, this emphasizes the need to be protective of public health as we work to reduce the use of dental amalgam. I must congratulate the countries that have made notable progress in phasing down amalgam, as this is truly a country-led approach. One project that approaches the phase down of amalgam with a public health lens is the Global Environment Facility, or the GEF-7 project. Started in 2023 for a 3-year duration, the project works across 3 countries, Senegal, Uruguay, and Thailand, to address the whole life cycle of mercury, from supply and trade to use, emissions, releases, and disposal. It's notable also that there are 141 parties that are participating since 2023. So, Dr. Jaigat mentioned in her presentation that there are 3 phases of this project. Phase 1 looks to improving policies and technical capacity. Phase 2 works to improve management of mercury and hazardous waste from dental use. And Phase 3 endeavors to manage the knowledge transfer and raise global awareness. And of course, there are corresponding deliverables. And these deliverables range from the production of technical reports and assessment reports in Phase 1 to the collection and proper disposal of dental amalgam waste, the installation of separators in Phase 2, and the creation of a global database, one knowledge hub, and a series of events and meetings and communication products in Phase 3. And the project continues to make concrete and definitive strides. When we look at the project country participants, starting with Senegal and what they have done, Senegal has already set up national oral health goals and a national strategic plan. They are reducing the consumption of sweetened food and beverages that we know key into oral diseases. And they are encouraging insurance policies for topical fluoride applications. They've also been promoting smart techniques for dental restoration in young children and the use of alternative restoration materials in children as well. Headed to Uruguay, and I'll do some translation here. Uruguay has modified their training programs where the amalgamation technique, clinical and odontotechnics is eliminated from teaching. And although there is no prohibition on the use of dental amalgam, they are recommending the proper handling, the proper disposal, and the ultimate processing of mercury-containing waste. Moving on to Thailand. Thailand is promoting the use of best environmental practices to reduce the expulsion to water and to land. And Thailand is also, through their Department of Health, they are piloting a waste management program and started the collection of data that we know would be critical as they implement different measures as part of this GEF-7 project. So ultimately, the GEF-7 project is working to accelerate the phase down of dental amalgam, and they are doing that by strengthening country capacities to do so. So coming back to there's no one size fits all, strengthening those country capacities. And as I mentioned earlier, these highlighted countries are not the only countries that are phasing down the use of dental amalgam. When we look globally, we see that estimates of annual global mercury use, and this includes all manufacturers of dental amalgam, estimates put that at 12 to 15 tons per year. So this is notably different from earlier estimates that place the use of mercury to be much, much higher. the data that we have is showing us a completely different picture. In fact, dental amalgam sales are trending downward globally. In 2022, sales of dental amalgam were the lowest it's been since 2013. So it's clear the phase down approach is working. Practitioners are moving to alternatives. When we look at the data again, we see that the sales of alloys, glass ionomers, and composites, all alternatives to dental amalgam, those sales have exploded and has actually topped $1 billion in 2022. Again, progress is being made. In fact, if we were to take a closer look at which regions were using dental amalgam, we would see that those regions mainly consisted of the United States, Canada, Europe, Australia, and the Middle East. And estimates of amalgam sales to the Africa region are less than 2% of total sales. So I want to leave you with a call to action that was laid out quite nicely in the WHO Global Oral Health Action Plan. Global target number 6 moves us towards 50% of countries having a national oral health research agenda that is focused on public health and population-based interventions. In order to achieve this, we need to prioritize oral health research of public health interest. We need to ensure research alignment with national oral health priorities. And we need to be sure that we invest in research for safe, environmentally sound, and mercury-free dental filling materials. There are a lot more actionable items that are within the GOHAP, or the Global Oral Health Action Plan. These are just 3 of those actionable items. And these 3 will continue to move the needle in phasing down dental amalgam. Because again, there's no one size fits all. So I thank you all for your kind consideration. Dr. Lipman, over to you.
Thank you, Makiba. That was an excellent overview of what is going on in terms of action steps to reduce the use of amalgam while preserving the public health in developing and developed countries. And I have been answering or responding to questions as they have been coming up. I am not seeing additional queries that directly ask specific things for the speakers. And I'm wondering if any of the presenters have any additional comments that they would like to share.
Maybe I can.
Sure, absolutely.
Just want to come back to one point, which is the research and the funding of the research. And so far, we agree that we need more research on alternatives. clinical testing. We have to concentrate also on what we call vulnerable groups, but on elderly patients with reduced saliva, where the composites may have a problem because of secondary carriers. And we need the resources for doing this research. The universities are willing to do these studies, but we need the support. And there is support from industry, but it would also be important to have support from non-industrial funding agencies to be able to supply the public with solid data on alternative materials.
That's an excellent point, because the development of new materials and development of techniques, and then their dissemination to institutions and to practicing dentists will be a critical piece in the reduction of amalgam use.
And especially if we have quite some funding from industry, and this is okay. But I think it would also be important to have funding from institutions which do not have a financial interest in this research area, so that we have both, of course, research from industry, but also independent research. This is, I think, would be very important. And I urgently ask for support for this sort of research.
I think that's an idea that everybody, no matter what side of the debate they're on, can get behind. Makiba, do you have any insights about advocacy efforts for country funding of research programs that will specifically target development of new materials or improvement of materials that are in development?
Absolutely. So I'm sure most are aware of the push towards universal health coverage and the inclusion of oral health within that. IADR and FDI has been really pushing for the consideration of oral health within the whole body. And I think when we get to the point where we start to include oral health, we can see more of the inclusion of oral health with the research for other diseases, because we are a risk factor for a lot of other diseases. And we have been here in the US trying to work and advocate for more funding for oral health research. And also on the global scale, we've been participating in a lot in the meetings by the WHO, trying to push for the inclusion of oral health and oral diseases. And we're hoping that with the incorporation of oral health within the UHC resolution, that we will see oral health being considered more frequently and dollars being put on the table to do the research that we need to, just across the board. I mean, amalgam is one component of that, very important component, but we need the merging of primary healthcare, oral health, so that we can see more research and more considerations for oral health across the board.
Right, and I think your earlier point about preventive efforts, and it was very exciting to see the WHO including fluoride materials, including fluoride paste, in their list of essential medications. That's a very helpful piece. But again, behavior change is a very difficult thing, and getting people to engage in routine oral health activities can also go a long way for improving or reducing the risk of caries.
Absolutely.
Yeah.
Oh, go ahead, Godfrey.
So just one point which came to my mind, which Donna has pointed out, that we also must support the local research activities. And I think this is especially true for the situation, just for instance, in Nigeria and in other countries. So I think this is an international enterprise and not limited to a certain part of the world, but should be internationally done and performed, because the situation in each country, as you pointed out, one fits for all does not work. The situation in each country will be different. And so we must find a solution for each country, which is optimal for this country or for this area.
Donna, did you have something that you would like to add?
Hello. Yes, indeed. Amalgam phase down is something that is already ongoing, even in my country. I can tell you that we have drastically reduced the use of amalgam, but there still remains the fact that there are challenges with using some of the adhesive materials when it comes to certain cavities. And like I said before, a lot of people haven't quite gotten into the right mode when it comes to using the alternatives. Okay, and so you begin to see a number of failures with the mercury-free alternatives, because we need to retrain people to the use of the mercury-free materials, especially the adhesive ones. Most of them are adhesive anyway. Okay, so, and I tell you that anecdotally, because I haven't quite done a proper research into that, but I'm getting reports of failures from adhesive materials, and people that begin to say, we are seeing failures, and that's not far-fetched. I already pointed out about the challenges that we may have, okay, with choosing some of these materials. So we really have to work hard to overcome those challenges if we are to make good success of going mercury-free. So that would be my take. More training in the dental schools, retraining, continuing education programs where practicing dentists are being taught the proper way to use these materials. Okay. Somebody talked about the expansion of amalgam, but the opposite is the problem with adhesive materials, where you have shrinkage and then you have leakage. So if you don't know how to handle it properly, you're going to run into a different set of problems with this. So we really need a lot of training before we can really say, oh, it's Eureka, we have found the alternative. Thank you very much.
You're welcome. And
oh, sorry, go ahead.
I was just going to say that it also points to an access of care issue, where people, if they have a recurrent issue with the restoration, being able to go back for additional treatment may not be a possibility. And that also results, as Gottfried was pointing out, that people may present initially with advanced lesions rather than something that could be amenable to a less invasive approach.
I just wanted to quickly add to what Prof said regarding the use of the alternatives. And during the presentation, my presentation, I talked about the fact that we're seeing an increase in sales of alternatives. So training is really, really critical, because if there are problems, we need to be sure we teach practitioners how to best handle those problems, especially since sales and we are moving in that direction. So I just wanted to point that out.
That is a very good point. And maybe that should be the point that we close with, that we need to continue with training and teaching and advocacy efforts on local levels and as well as on the world scale.
Thank you very much. I think, like you pointed out, I don't think there are any specific questions anywhere in the chat, perhaps? No? No
No.
specific questions.
I do think we are out of time as well. So I do want to thank everyone for coming this morning. And Ruth, I'll let you just close up, final words.
Thank you. So
Okay.
thank you for joining us. This is a worldwide effort, and I think that we all need to work together in order to bring about the goal of improving oral health at the same time as reducing dental amalgam use. So thank you.
Thank you. Okay.
Thank you, everyone.
Thank
Enjoy
you.
the rest of
Bye-bye.
your evening, your day, depending where you are. Thank you very
Okay.
much.
Thank you all. Okay.
Bye.
Okay. Bye-bye, Donna. Bye. Bye-bye.